All right, so this is episode 3 of the Redefine Health Ed podcast. Thanks for joining us, everyone. I'm your host, Dr. Katie O'Bright, and tonight we have one of our keynote educators, Dr. Lance Mabry. Dr. Mabry is an assistant professor at Highpoint University, where he teaches primary care and the Professionalism and Leadership series. He graduated with a BS in biology from Wilkes University in 2002, and with his DPT from U.S. Army Baylor University in 2007. He completed a manual therapy and primary care fellowship from Kaiser Permanente in 2011. Dr. Mabry has retired from the United States Air Force after serving in both Operation Iraqi Freedom and Enduring Freedom. He is currently the vice chair for the Triad District of the American Physical Therapy Association of North Carolina. That's a mouthful. Dr. Mabry has 24 publications focusing primarily in diagnostic imaging and primary care physical therapy practice. What's up, Lance? How's it going?
Hey, how you doing, Kate? Well, thank you so much for having me. I mean, per our discussion off camera, I do expect that you put some sort of filter on here to make me look like Brad Pitt or Chad Cook or somebody else beautiful. So
yeah, something like that. You've got an excellent background, although most people listening to this are probably just going to be listening and not viewing. However, so that you do have that going for you, but the background really suits you well. For those listening and not viewing, Lance's background tonight is in very fitting X-ray radiograph, of the ankle and foot complex. I think I see, I was just going to say, I think I see a navicular over your shoulder. There's okay. Yeah, there we go. Oh, there we go. There's a fracture. High fracture, fibular fracture.
So yeah, this is a transsyndesmotic fracture of the fibula right here behind me. If you guys are watching this, so I'm forgetting. I just published 2 transsyndesmotic fibular fracture studies in the last year or so. One of them was in JOSPT, and then one of them just came out last week in JOSPT cases. And,
oh my gosh, I didn't know that. I'll have to look at that.
Yeah, so Dr. Tara Fisher was the lead on the one we just published. So I'm not sure which one this is from. This is from this is either a non-displaced or a stable, transsyndesmotic fibular fracture in a skateboarder, which can ultimately be managed conservatively with physical therapy and things like that after some immobilization. Or it's a very similar image in a patient that Dr. Fisher had in a pararescueman that had a jump with a parachute, an ankle injury, and then an unstable fracture that ultimately ended up in surgery. So the 2 serve as kind of nice bookends if you guys are looking for that, because essentially knowing how to manage this, essentially you have to add in a stress radiograph series to see where this will ultimately land, whether that be in PT or whether that end up in orthopedics. So the 2 cases are really cool when you put the 2 of them together.
That is such a good intro to what we're going to be talking about tonight, which is PTs and imaging in general, not just diagnostic imaging, but imaging to help with the decision-making process in differential diagnosis. And, funny enough, before I move on, speaking of fibular fractures, I have to have a shout out to my old boss, Lieutenant Colonel retired Pete Contos. Doubt Pete is ever going to listen to this, but if you do, Pete, so Pete actually had I swear his fracture looked so similar to that. And guess how he did it? So we were all active duty at the time. He might have actually been a civilian by that point.
Was it Ultimate Frisbee? Ultimate Frisbee is like the Frisbee keeps me in business.
Pretty sure he was called out on the field during his son's soccer practice and was just running on the field and broke his fibula. So yeah, Pete, I hope your ankle's doing well. He did manage it conservatively, which is great, but yeah. So anywho, moving on. So Lance, can you just tell us about yourself? I sort of gave you an intro, but that's the formal kind of BS that nobody wants to know about. Tell me your story. Give me the next 3 minutes and just tell me your story.
Yeah. So, I mean, kind of my background, I was I started off in the Marine Corps. I went into the Marine Corps after high school.
I didn't know that.
I did. Yeah. I was actually a cook in the Marine Corps. So I got in the Marine Corps right after high school at age 18. I was a cook in the Marines. They gave me a list of they gave me a list of jobs, and well, frankly, let me take a step back.
Well, wait, okay, first of all, where are you from? Because I don't even know that.
Yeah, so I'm actually from Pennsylvania, Reading, near Philly.
Oh
So,
my gosh.
so in my 18-year-old brain, things financially didn't work out in for college. I had a good high school transcript and things like that, but we just, frankly, our family couldn't afford college. So joined the Marines, and in my 18-year-old brain, the Marines were the ones to join because they had the best uniforms, and I thought all the services were the same, and the Marines had the uniform, and therefore that's the way.
They're definitely the most badass. Let's be honest.
Yeah. So I joined the Marines, and they gave me a list of jobs that I could have, and they were all very operationally focused. It was you could be artillery, or you could be infantry, or you can be a combat engineer, and as I was going through the list, I was like, wow, all these things sound really specific to the military, and doesn't sound like it has a lot of transferable skills to the civilian sector. I mean, how many times in the civilian sector do you have to sweep for bombs and things like that? So and then I got down to cook, and I'm like, oh, cook, like that could be great. I could learn how to cook, and let's do that. And so joined the Marines out of high school. Ended up going to college at Wilkes University. Again, I was kind of focusing on physical therapy. At the time, the split programs were pretty popular, where you do your
like the 3 and 3.
Oh yeah. So I was looking at that, and actually got actually started taking some of the Air Force ROTC courses because one, they were free, and hey, free credits, right? I mean, enjoy that. But then two, just to learn more about a sister service with the Air Force and the rank structure and things like that. And ultimately they offered me a scholarship and a commission. And while I loved the Marines, it was time to move on. The Marines didn't have medical. All their medical runs through the Navy, and this looked like my pathway towards physical therapy. But physical therapy in the Air Force is kind of tough to get in once you're in service. There's only 2 people a year accepted to Army Baylor. So I went to my first base in Robbins Air Force Base as a communications officer. My undergrad was bio pre-med, and they said, man, we got to get this guy in charge of some computers. So there I was in charge of computers, and applied to Army Baylor. And unfortunately, I got turned away from Army Baylor. They only accept 2 a year from the Air Force. And so then I applied.
Hey, Lance, you're not alone. I got rejected too, but still went into the Army.
So then so in that year between application cycles, I ended up going all over to Iraqi Freedom at Qatar, and I applied again, and I actually got the word while I was in the Middle East that I got accepted into Army Baylor, which was,
wow, that's awesome.
Which was exciting. So it was my second year was a charm, and went in, and I think my story when it comes to imaging, we had an imaging class at Army Baylor, and I think one of the misnomers that gets out there, and one of the things that civilians need to understand is there's this misnomer that military personnel have some sort of like super secret special training diagnostic imaging.
Yes, there is a huge for sure.
So, and I think a lot of it stems from the 2011 Boyles article that talks about, they talk loosely about the Colonel Kersey course and things like that. So there's this perception that we have some sort of
secret sauce,
wonderful training, and all these other things. And frankly, I don't know that it's the case. We had a course at Army Baylor on imaging, and it was taught by a radiologist. And the radiologist came in and he showed us all these wonderful pictures on osteomyelitis and things like that. But I didn't even have the basics. Like, I didn't even know what a normal looked like, or how to orient myself, or finding basic anatomy, or when to order it, or
when it's indicated.
Yeah. So great. That's what osteomyelitis is. I don't even know what osteomyelitis is, let alone what to look for. So, I went through the class, and I don't think I really got a lot from it. And I thought I knew a lot about imaging because, they taught us about the Ottawa ankle rules and the Ottawa knee rules.
Yeah.
So I get out to my first base at Travis Air Force Base. And now all of a sudden there's patients in front of me, and I'm expected to know when to order these images. And, when my first patient walks through the door, and now all of a sudden I have to face that decision, and I realize, oh, well, it's not an acute ankle sprain or not acute ankle injury. So it has nothing to do with Ottawa knee rules or Ottawa ankle rules or Ottawa, Canadian C-spine rules. a lot of these patients are chronic pain or have had pain for a while or gradual onset or whatever else. So they don't really fit the rules. So now what? And that was when I was like, oh God, I don't know enough to help these patients. And I'll never forget my very first imaging order was of a patient with low back pain. I saw him on 2 occasions. The first time I saw him, we worked on some things. He came back the next day and said he was doing better, all was well, everything else. And then right as he's leaving, he kind of had one of those, oh, by the way, comments that, that he didn't bring up during his initial eval, which was, something along the lines of, oh, by the way, this all started after I had this fall. And he had some sort of significant fall. So I don't know, I'm a student at the time and I'm like, I don't know, like he's feeling better. But yet he had this fall. Should I order imaging? Should I not? So I ended up ordering imaging on the guy, and turned out that he had diffuse idiopathic skeletal hyperostosis, or for those that are familiar, is DISH. It was frankly just a lucky catch. I mean, the fact that I ordered it and that's what he had, I've never again seen it in my career, but when I communicated to the radiologist, I didn't know what to say to the radiologist. I had no one ever taught me how to communicate. So to a radiologist. So I just wrote in the indications, rule out spondy. And I shortened it to spondy because literally I wanted to be ambiguous enough to fit for spondylolisthesis, spondylolysis, spondylolosis. I mean, like, really, I just didn't know what I was doing. And so I had a great mentor there in Mike Ross. Mike Ross is one of the pioneers in imaging for the Air Force. And he pulled me aside and he said, did you just write a consult to radiology that said rule out spondy? And I said, yes, I did. And he said, okay, you do that ever again? And so he kind of took me under his wing and we kind of went through what needed to be ordered and whatnot. And that's when I really realized, wow, I don't have the skills that I need in order to treat these patients. And on top of all of that, I looked back at the training I got, specifically in regards to imaging at Army Baylor. And while I think it was potentially fantastic for someone that was further along than what we were as students, I don't know that we had the skills to really keep up with what the radiologist was laying down at the time. And that's when I realized, man, I think I can do this better. I think not only do I need to know more, but I think that I can learn it and then convey it in a way to other PTs that it's not as complex and not as convoluted and not as gray. And that is a pun because everything in imaging is gray, but not gray as what we got. So I've really just devoted my career to it and breaking it down and making it in layman's terms and making it in terms that clinicians can easily understand and easily learn quickly and with little effort. So that's what we did. So for me,
I'm gonna jump in here and just comment on that. So, like I said, I got rejected from Army Baylor, and I went to Temple University, best education I could have gotten, honestly. I was one of those weird people that did ROTC and got an education delay to go into the Army. So I did ROTC in undergrad, and then that's how I got my entry in as a physical therapist. So I went to Temple, and my education in imaging at Temple was given by Bill Egan, who first of all is a bro, and I love him so much, and we still are in contact. But he was also he was an Army Baylor grad, so I kind of had that one up. But the education that I got was a civilian education, and it was all of the stuff that I needed as a clinician in order to determine what imaging studies are appropriate when, what imaging modalities do, and what how much exposure to radiation they have, and how they work, the MRI and the hydrogen protons and blah 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 blah. So I started there, and I went directly into the Army and really didn't have any other imaging training outside of that. And I was good, but being able to practice using that modality coming straight out of school, having that education, hi sweetie, was probably the best thing that I could have done. I think the issue is a lot of people, even now, even if they do have good imaging in their curriculum, they're not really able to use it for the most
Right.
part when they come out of school. So then they forget how to use it, and then they never have experience communicating with radiologists. So then they just don't really know what they're doing with it.
Yeah.
So the secret
big.
sauce, that everybody thinks that everybody has in the military, I think that secret sauce is really just being able to utilize the modality and being able to have experience communicating with not only radiologists, but other healthcare professionals.
Yeah.
So I think that was a really good thing that you brought up. So now I'm definitely curious. More, I would love for you to tell me more about why, like, what do you think is important for clinicians to know about how to communicate with radiologists?
Yeah. Well, a couple things. Let me double down on what you just said a second ago, right? So, in the Air Force, like we said, only 2 people a year go through Army Baylor, but it's not uncommon for the Air Force to bring on 8 to 25 PTs in a year.
Right. Same with Navy.
Yeah. So, which means that all of these PTs are coming from the civilian sector, and they're expected to learn how to know imaging with the civilian education. So again, there isn't some sort of secret sauce that the military has. There isn't some sort of, it's, these civilian clinicians will come in with the education that they have. And it's absolutely right. I think it's the ability to use it every single day. If you use it every single day, you get better at it. So I think civilians need to understand you are just as good, or you can be just as good as any military PT in imaging if you just use it every day. And as far as communicating with radiologists, we talk about that in our introduction to radiology lecture on introduction to musculoskeletal imaging lecture on redefined health. So I don't know if I want to give away the house on that, but I do think that what clinicians need to understand is they need to understand that you cannot simply say things like foot pain and then expect to get
Preach.
Yeah. So everybody complains about imaging, and they say, the findings never clinically correlate, or radiographs always are unremarkable, or whatever. It's all of these complaints about an imaging modality, and in reality, imaging is nothing more than a tool. And I would say that 99% of time, the frustrations that I'm seeing from people are not because of the imaging modality. The imaging modality is doing exactly what it's supposed to do. It's the application of that. So there was a study that came out a couple of years ago, and they were looking at intra-rater reliability between radiologists. And essentially, they sent this patient to 10 different radiology clinics, and they had the patient get MRIs of these 10 different clinics, and then ultimately the radiologist read the image. But there wasn't really a case vignette to the radiologist. All it said was back pain and leg pain, and that's it.
Yeah.
There was no information. So the radiologists were blinded to what's going on. They didn't know what they were looking for. And radiology, just like every other profession in medicine, it's an art. If you send a patient to 10 different physical therapists, there's a distinct possibility that they're going to get 10 different diagnoses. And if you send a patient to physical therapy, orthopedics, and podiatry, all for foot pain, there's a good chance you're going to get different diagnoses. So, radiology is no different, but radiology, gets all this grief about it. And, on top of it, if you're going to send a patient to primary care, if you're going to send them to orthopedics, if you're going to send them anywhere else, that provider, in theory, maybe not in primary care, but at least in orthopedics, they're going to get some kind of evaluation.
Right. Some kind of physical exam.
Yeah. In radiology, that doesn't, a lot of times the radiologists aren't even in the same state as the patient. So
right.
You have a situation where the radiologist can't examine the patient, and then the clinician that's referring is conveying no information to them at all. And now they expect the radiologist to somehow divine the answer to what's going on, and they have nothing. They have no information at all. So it's important for clinicians to convey a clinical vignette to the radiologist, so the radiologists know what to look for. They know what to tell you if it's there or not. So if you're concerned about a stress fracture, but you don't tell them you're concerned about a stress fracture, they may or may not even comment on it. Obviously, if it's there, they'll talk about it. But if you say, I'm concerned about a stress fracture, and if there's not one there, they will literally put that in the impression, no signs of fracture. If you're still concerned, consider whatever else. But they can't do that unless you communicate with them. So
right. I remember one case when I was in the Army. It was I was at Fort Sill most of the time that I was in. And at Fort Sill they have this like old school, they really only use them for ceremonies and stuff, but like the cavalry. So this soldier was assigned to the ceremony. I don't even know what they're called, like the ceremony team, and his horse threw him. So he was thrown from a horse. These are not just little horses, they're like the big legit horses. I don't know crap about horses, but anyway, he got thrown from his horse, landed on his back. He just kept complaining of this terrible back pain. And he had an x-ray, negative, radiograph. He had a radiograph negative, had an MRI negative. This is a 20-year-old male. And when I examined him, I remember him nearly jumping off the table. I was in like the L2, L3 area, off to one side. And I was like, man, that is the one spot that's reproducing his pain. That's it. Like, let's go back and look at his imaging. So I went down. Luckily, I was in a clinic. I was in a primary care clinic where the radiologist was like right down the hallway. So I walked down the hallway. I walk in with Dr. Berman, and I'm like, hey, can we just take a look at this guy's radiograph? Let's look at the left L2-3 transverse process. And he starts scrolling through. And sure enough, like right at that transverse process, he had a fracture on that spot. And it was just like and then I went back and looked at the orders, which I didn't order the initial studies. They were ordered in urgent care. The initial orders were just like thrown from a horse, back pain.
Yep.
So you have to be able to be specific enough and tell the radiologist where to go and where to look and what to look for.
Yep. Yeah, no, I think it's such a good point. And I think the other point that you hit on there is radiologists are obviously and clearly and without debate the best providers in the world at looking
100%.
So that being said, I would argue that a radiologist looking at imaging by themselves versus a radiologist looking at the imaging and the clinician looking at the imaging, two sets of eyes, will always be superior. And that is not a ding on radiologists. They are the experts, but also simultaneously we have the patient in our rooms with us. So
right.
I had a very similar experience when I was in Afghanistan. So we had a young lady that she sustained an injury. She was actually tiny lady. I mean, she was probably 100 pounds soaking wet. And the Army and all their infinite wisdom said machine gunner. So now she is done up in a not a flak vest, a bulletproof vest, which is like super heavy. It has those on it, super heavy. She has her helmet on. She has the machine gun, which is exceptionally heavy.
Yeah.
All of these rounds. She has her chem belt. And frankly, she probably had more equipment on her body than her body weighed in itself. That's how much it was. So anyway, they have her loaded up in the back of an 18-wheeler, and they had her jump out of the 18-wheeler. She lands, instant onset of ankle pain, and hasn't been able to walk since. So this is roughly 2 weeks before they get her back to us at Bagram Air Base. And interestingly enough, they actually had, so where she was, they didn't really have a whole lot of medical assets, but they did have the EOD crew. So the EOD crew had the little robot come out and x-ray her ankle. And so the robot x-rayed her ankle and then came back with the x-ray, and she's like, yeah, but then they gave it to the EOD crew and nobody could read what the x-ray said. So I have this x-ray and I don't know. So
that's funny. I did not know that was a thing.
So she anyway, she comes in to our MTF. She gets an x-ray. I don't think I ordered it. But she comes in and sees me, and her entire leg from her knee down to her toes is black and blue. And her whole thing, and this is 2 weeks out. And it's one of those ones where, I mean, as soon as you start getting good at this, you can sometimes just look at someone and be like, oh, well, that's fractured. You know what I mean? Mm-hmm. So, but then I got the radiology report, and it largely read as normal. It was talking about a little bit of an avulsion of the fibular, the distal.
Yeah.
So but whatever. That
Like a
just
chip fracture, little,
yeah.
insignificant. Yeah.
Right. But that clinically, that's irrelevant. But
Right.
so I'm like, okay, like that sounds crazy. I mean, I know this has to be a fracture. Like I can look at her and see this is a fracture. So I pulled up the images, and there was a line through the talus. So anyway, I went back and I talked to the radiologist, and we were kind of back and forth a little bit. And so ultimately he agreed to order a CT scan. And sure enough, when he ordered a CT, it was actually a burst fracture of the talus. There was some, I think the sustentaculum tali was fractured. There were
Oh my
like
goodness.
fractures, she fractured everything, right?
Yeah. In
And
other words, jacked up, really jacked
yeah.
up.
So now this is the difference between a soldier being told, suck it up, it's just an ankle sprain, get back in the field. And now this soldier being pulled out of theater because she can't protect herself because she has a burst fracture of the talus, right? And it's all because that I as PT looked at the image, and with the understanding that I have all this information here at my fingertips that the radiologist didn't see. So it's not that the radiologist missed something. It's not the radiologist was lacking or whatever else or made a mistake. It's just literally we have the patient right there in front of us. So getting
Right.
a second set of eyes on it is so important.
It's so huge. I'm this conversation has been awesome, by the way. We're going to take just a very quick break here, switching to commercial mode slightly. So Redefine Health Education, what are we? We were founded in 2020, and we are a live virtual continuing education company. So if you are looking for continuing education courses and you just don't want to pay to travel, or don't have the time or the means to travel, and or you want to be able to be comfortable and sit in your jammies with your dog or whatever at home, that is what we specialize in. So we have a couple of upcoming courses that I just want to mention. We've got the Patient Educator Summit, brought to you by Physio Sage, coming up on Saturday, June 12th. Redefine Health Ed is sponsoring that summit. So check that out on our website. We also have on Monday, June 14th, it's a 1 hour. So who can't sacrifice 1 hour? It's a 1 hour course called The New Worlds of Rehab, Addressing Burnout. And it's going to be taught by Dr. Ari Ginsberg, who is a physical therapist, but he also has a master's in psychology. So he really talks about the psychology of burnout and how that process happens and how to prevent it. So again, take a look at our website for that. And then finally in June, we have on Saturday, June 19th, we have Paying It Forward, the why, what, and how to mentoring students and young clinicians. One of my former classmates, Dr. Mike O'Hara, and his partner, Dr. Mike Steimling, are teaching that course. It's a 3-hour course. And really one of the things that I have always found, especially as a student and as a new clinician, is that there is an art to being a clinical educator. And a lot of people don't have that skill, but they're yet forced to be clinical educators. So if you feel like you're kind of in that boat a little bit, jump on this course. It will definitely be worth your while. Okay, so we're transitioning back here. Lance, I want to know, what research are you currently working on?
Oh, wow. Well, thanks for asking. We have a couple things rolling right now. So we were lucky enough to get a couple of things put out in JOSPT cases last week, looking at implications of imaging in clinical practice. But the big study we're working on right now is we just completed data collection on our study titled Are Physical Therapists Practicing the Requisite Skills to Refer for Imaging? And the concept behind the paper was we started looking at some of these state practice acts and what we need to change them, and some of the board rules and things like that. And essentially one of the requirements in certain states was we have to demonstrate that physical therapists are practicing a skill in order to have the skill added. But it's hard to demonstrate practicing the skill in order to have it added when it's distinctly prohibited by law. So how does that work, right? So
Man.
Yeah, it's a little bit of this catch-22. So the idea behind it was, okay, as physical therapists in clinics, we understand that in many states, we might not be able to refer directly to a radiologist. However, we're still screening for patients. We're still using evidence-based guidelines. We're still determining what's going on. And that referral ultimately goes somewhere else, whether that be ortho or the primary care provider, instead of radiology, and it just adds that extra layer. So our concept behind it was, well, I bet you if we ask people, they're doing all of these things, but they're doing all these things and they just can't get it to the radiologist. So therefore, in that case, it's not a prohibition on imaging. It's not a prohibition on using imaging skills. It's not that we're asking for an increased scope of practice, because we're already doing all these things. All we're asking for is stop prohibiting us from referring to radiology. There's no other referrals that I know of that we're prohibited from doing. So why are we prohibited just from referring to radiology? So
absolutely. I'm going to throw a caveat in here. So I'm not practicing right now because I just had shoulder surgery, but last year I saw a patient who was doing a running program. And again, this is outside the military, keep in mind. So she was doing basically a couch to half marathon. She ramped up really quickly. She's in her early 30s and she's complaining of all this groin pain, right? So immediately, especially coming from Fort Sill, which is a basic training installation, tons of stress injuries, immediately my head goes to, okay, she's probably got some sort of stress reaction, something's going on. So I'm like, okay, I do my physical exam. Everything is pointing to, I need to know if she has a femoral neck stress reaction, stress fracture. So what I do is I immediately pick up the phone and try to get in touch with her primary care provider. Her primary care provider is not available. I'm only able to talk to a secretary. It takes 1 week, an entire week, for me to get someone on the phone. And this is me trying to really like help this patient, get her off her feet, deload her so that she doesn't have to go to the emergency room, urgent care, because she was very adamantly against that. Trying to prevent that just so that she can, first of all, get an x-ray. And if the x-ray is negative, then get an MRI. And sure. It takes that long just to get in touch with somebody to be able to order an image that I know is necessary. Yep. And that is why this is important. And sure enough, it comes back, her radiograph comes back negative, order an MRI. She has a femoral neck stress fracture. Like, yeah. So let me just order it. Dang it. Yeah. This is why that's important.
Yeah, and it comes down to, one, obviously, especially with femoral neck stress fracture, right? The sooner you get it diagnosed, the better outcome, the more risk you reduce. It's for the patient's benefit. I work in a pro bono population right now, and a lot of our patients don't have primary care providers. A lot of our patients don't have access to imaging. A lot of our patients are reasonably destitute financially and can't pay for anything. So we're kind of in a position where we're limited a little bit in all those things, right? So I don't even have an outlet to go contact a primary care provider for many of our people. So so in the one that we just published a couple of days ago, one of the ones I really want to bring your attention to is one by the lead author is David Collier. So I'm the last author on that one, and so David's one of our students at Highpoint University. And he got this post-operative patient with, he was post-operative rotator cuff, and he was, 2-3 months out. And as he starts describing his symptoms, they don't at all sound like a post-operative rotator cuff. He's talking about a lot of numbness, fumbling, difficulty with buttons. He can't write his name. He looks up and he gets very, dizzy and things like that. So, so now all of a sudden we're thinking maybe, some sort of neck pathology or whatever else. We tested him out. He had all this hyperreflexia. So long story short, we were concerned for a cervical myelopathy. So right. Ultimately, we were lucky enough to have access to an ongoing research study that allowed us to get an MRI for this guy. But otherwise, he would have gone without. And the MRI ultimately showed that he had myelomalacia, which is radiologist term for what we would clinically call cervical myelopathy. And then ultimately we ended up getting to a surgeon right as COVID kicked off, and he was able to get decompressed. So in a case like that, time is
wow.
super, and without having the access to the imaging, that guy may have never gotten it, with his limitations financially and things like that. So giving us the ability to do that is super important. And, so we put this study out, and we were looking at the study we were talking about before, collecting data on how often PTs are using imaging. And the results we're getting is pretty profound. I mean, the imaging is being widely used in physical therapists. And it's just that prohibition on referral. It's not, we're using imaging skills all the time. So we're in the process of writing up that manuscript now, with hopes of submitting it in the summer or fall. And I think it's going to have some pretty interesting impact.
I think that's great. And I think that it's so incredibly necessary, because we're all learning this in school. It is part of DPT curriculum. You're going to get something different at Highpoint that you would at Temple, that you would at different places, but we all are educated in how to use and how to use and when to use imaging. So I think that it is incredibly important for that reason, because it limits patients' access. It just doesn't make any sense. I mean, in the case I was talking about earlier with the stress fracture, this was a very busy working mom with 2 young kids at home. She was convinced that she didn't have anything wrong and was not going to go to the emergency room or urgent care. I trust me, I tried. So with her, I could have just ordered the imaging myself, and I wasn't really allowed to. And that's really interesting coming from, I think, a lot of military PTs that were once military PTs and now they're out and they can't really use it anymore. It's exceptionally frustrating.
Yeah.
So Lance, I want to know what drives you on a daily basis. What keeps you going?
I think my vision, if I can contribute a little bit to the profession, is I want to be one of the key players in getting diagnostic imaging to be legal in every state for physical therapists. And, that's driving what I'm educating my students in. That's driving my research. That's driving my advocacy efforts in APTA of North Carolina. And I think we're seeing, some success with that, right? I mean, there are a couple of models now. Both Wisconsin and North Dakota now have imaging in their Practice Act. So once it's law, it's really hard to take it away. So that looks like it's going to be there probably for forever. Colorado has a different model. So Colorado actually got it through their board rules. So they actually have an official board rule that says that it is okay for physical therapists to refer for X-rays, MRIs, things like that. That's a path of lesser resistance sometimes than actually going through the political process with legislation. So that might be a pathway forward for a lot of states. Utah actually has a reasonably different model. They actually got their Utah PTs can order imaging because of what is in the Radiographer Practice Act, not what's in the Physical Therapy Practice Act. So the Radiographer Practice Act says that they can accept referrals from a physical therapist, which is kind of an interesting aside. And then, some of these other states, like I think Maryland or DC, both got theirs through board decisions, not necessarily official board rules, but I think people wrote a letter into the board, and the board ultimately made a decision. I wouldn't advocate for people to do that independently. If they want to do something like that, it's very important that they coordinate with their state chapter to make sure that it is a well-founded letter, because if you just pop off and send a letter and it's not well supported, and now the board makes a decision that imaging isn't right, you kind of set us back. And then there are also some other states like Pennsylvania and New Jersey. The word we're hearing from the imaging SIG is that PTs in Pennsylvania and New Jersey can actually refer for imaging. And the reason actually lies within the silence in their Practice Act. So it's not because
I'm so glad that you brought this up.
Yeah.
Keep going.
It's not because of board rules. It's not because of a board decision. It's not because of legislation. It is simply because nothing says they can't. So
thank you. I'm going to tag Heidi Oja on this podcast so that she can listen to this, because Heidi was the one who told me, she was like, our Practice Act is silent. It doesn't say you can or you can't. And it was really the same thing with dry needling. When I first moved to Pennsylvania, everybody in the entire state was like, we can't dry needle. And I looked into it. I checked with the board. I checked with the PPTA. I talked to an attorney. I did my due diligence, and everybody said, you're certified. It doesn't say you can, doesn't say you can't. But I thought the same thing with imaging. And here I am. I'm a cash-based PT in Pennsylvania, And I just didn't have a means to refer. And I knew tons of people around me that were saying, no, you can't refer for imaging, even though the Practice Act is silent. So I'm so glad that you brought that up. Thank you.
Yeah. So what we're hearing from the field, so a couple things. One, a lot of people aren't aware of what the rules are. So,
Right.
so we're pulling some data, and I'm not going to throw the baby out with the bathwater with some of the data we're pulling, but some of the data we're pulling in some of these states that have had imaging for a long time. I'm not going to say a state specifically by name, but there are some states that have had imaging now for a long time for physical therapy. And we looked at what percent of people thought that their state had imaging, and a substantially high number in the 40s percentile, 40% said that they thought their state didn't have it, even though their state has had it for years and years and years.
You're kidding.
So they're not getting this information. So I don't know if they're not, keeping current. I don't know if they're not APTA members, so they're not getting the word, but there are a lot of PTs that think they can't, even though it explicitly says they can. The other thing I'm hearing from the field is, well, how do I can't order it, or how I can't refer. How do I refer? And my thought is, well, shoot, how do you refer to everybody else? How do you refer to PCP? How do you refer to orthopedics? How do you refer anywhere else? I mean, it's in your electronic medical system, whether that be through your health record or whatever else. If it's not, you can get a script pad. Contact a radiology clinic around you. They probably have the script pads that you just fill it in and give it to them in paper. And then the thing that I hear the most is that people say, oh, well, I don't want to do that because insurance won't reimburse it. And then my hook. So what we're hearing, and there was actually an interesting discussion about this from Connie Kittleson. She was the president of Wisconsin chapter, and they put out a survey. I don't know if they ever ended up publishing it, but looking at Wisconsin PTs, and there was this huge response from Wisconsin PTs that said, insurance won't pay for it. But then they followed it up and said, have you ever had an incident where insurance didn't pay for it? And everybody said no.
They just never tried.
They never tried. So they just assume that it won't get paid for.
Yep.
And try and they give up. But when you actually look at the people that are referring, I mean, at least from the state chapter standpoint, nobody's hearing any issues with insurance reimbursement for this. I have heard some anecdotal things, but nothing on a higher level. And then when you actually look at Aaron Keel.
I was just about to bring up Aaron Keel because I went to his talk on that, and he published a paper on it.
He published a paper. 100% of the images that they ordered in that study, 100% were reimbursed by insurance. So it seems to be an unfounded fear. All these therapists think it's not going to get
Yes.
You don't know until you send the patient. You don't know. And then if it doesn't get reimbursed, that's the time to have a conversation about, this is what it says in my board rules here. This is what it says in my Practice Act. And that's when you get a chance to advocate for the patient and move the profession forward. So I think physical therapists need to stop getting out of this I can't mindset. And yes, we can.
Yeah.
We can do this.
You think it's a little imposter syndrome? Like we were talking about this the other day. You think it is like a little imposter syndrome, or just kind of the fear of the unknown, a fear of uncharted territory?
So imposter syndrome. So what I will say is when you look at the education that's out there, right? So you start digging into some of the research. 20% of physicians reported they had no musculoskeletal education at all. 30% of physicians report that they self-taught musculoskeletal. 80% of physicians can't pass a basic musculoskeletal exam. Nurse practitioners and PAs have similar trouble. I think they have like 8 hours of musculoskeletal care, musculoskeletal education. I was talking to a physical therapist at a premier medical school in the United States. I'm not going to say which one it is, but one of the top physician schools in the nation. And they asked him to revamp their musculoskeletal education. And he said, okay, how many contact hours do you have for musculoskeletal? They said 1 day. It's 8 hours on a Tuesday. That's it for the entire body. Differential diagnosis, everything else, right? Now,
for those of you listening and not watching, you should have seen how big my eyes just got. It showed all the wrinkles in my forehead, I swear.
So, and to say all this is not to say that physicians are bad.
Yes, please understand that.
Right?
That's like my number one thing that I always want to get across whenever we talk about stuff like this.
Yeah, it's not to say that they're bad at this. It's they are the best at what they do, right? Physicians, PAs, nurse practitioners, but they have other stuff they're worried about, right? They're managing hypertension and they're managing diabetes and they're, looking for all these other things. But musculoskeletal, that's where we're at, right? And unless orthopedic surgeons are going to take every single back pain that walks through the door, which is unlikely, we are the single best trained and most educated provider in the world for these patients, right? But yet simultaneously, I hear PTs shunning that responsibility, right? Well, I don't want to get sued. Well,
I'll just refer back to primary care.
Yeah, in the Moore et al. Study, 2005, not a single physical therapist had any litigious action. I published one last year in Military Medicine on the safety and utilization rates in primary care physical therapy, and there were no lawsuits, there were no administrative actions, nobody had board actions taken against them or their license were lost. There was no injuring of any patients or anything like that. So, everybody, oh, well, I don't want to get sued and I don't want my insurance. What are we talking about here? Like, so we're gonna pass that decision off on somebody that is comparably lesser educated in this space, very well educated, but comparably lesser educated in this space. And that's not fair to our patients. And then, and then simultaneously, I'll hear people complaining about, why are physical therapists not, getting increased pay, and why are physical therapists not, increasing this or increasing that? And my thought is, okay, well, how many times were you in a gym counting to 10 today? I mean, if you're in a gym counting to 10 with your patient's mini squats, maybe you don't need 6 figures for that. I'm just saying, maybe that's something a technician could do. Maybe that's something a PTA can do. And maybe we can do the things that doctorally trained musculoskeletal experts are put on this earth to do. And that's, to look for pathology, to screen for diagnosis, to manage our patients, right? And managing our patients takes a much higher level of skill than treating our patients. Anyone can treat a patient, but managing a patient, that's next level. So that's where we need to get as physical therapists. But one of the main ways we get there is going to be through imaging.
Absolutely. Thank you so much for saying all of that. So we're kind of at time for this episode. I would love to do a follow-up with you on this because I feel like there's so much more to unpack here. The 2 things I would love to do in another episode would be talking about, like, there's some states that have explicitly said, to my knowledge, physical therapists can order radiographs, but they can't order MRIs, CT scans, ultrasound, that kind of thing. So why that is and what your opinions are on that. And then talking about, because a humongous thing in healthcare across the board right now is the overutilization of and misuse of imaging. So I think that that's something that we really definitely need to talk about, because I guarantee you every physical therapist listening to this episode is going to be like, well, why do we want to contribute to that problem of overutilization and blah, blah, blah. And I actually think, this is just my opinion, that because we're so skilled in musculoskeletal differential diagnoses, we would actually be a better healthcare professional to order musculoskeletal imaging, because we would do it in a more accurate and appropriate fashion than people who just are confused and don't have no idea why somebody is having back pain or knee pain. So they just order an x-ray and figure that that's why, whatever the report says is why they're having pain. So I would love to unpack those 2 topics in another episode. I would love to finish this episode with just 2 silly questions. I like to end on a light note. So, Lance, would you rather? Okay, I just had my would you rather questions pulled up and now they're gone. Hang on one second. Okay, would you rather lose your vision or lose your hearing? And you can take a minute. No rush. Lose your vision or lose your hearing.
I mean, how quickly do I need to respond to that? So
pretty like right now.
Yeah. So if I have time for a quick story on this.
Sure.
So I told you that I started off in the Marine Corps when we very first started this talk. And, I decided in my infinite wisdom that being a cook in the Marine Corps would be the best path. But little did I know that when I was joining the Marines, that was at right about the time that they were phasing out cooks and they were replacing them with civilians, stateside.
I did not know that.
So I show up to my unit, and my unit was a machine gunner and motor trans unit. And cooks were there too, but they're like, well, we don't need cooks to cook anymore. So, so do you have a special license to drive a truck? And I'm like, no. They're like, well, guess what? You're a machine gunner. I'm like, huzzah. So, so we're doing squad assaults on with machine gun outposts and whatever else. So anyway,
this is reminding me, I'm having like flashes of Pearl Harbor.
Right?
Have you seen that? You know what I'm talking about? Like yes.
Yeah. So remember, we were about ready to shoot the 50 cal machine gun. Up at Fort Dix, they have the tanks on the hill and whatever. So we're getting this safety brief, and they go through the whole safety brief before we shoot the 50 cals. And God, the 50 cals, like the bullets are like 6 inches. They're like cannons.
Humongous.
Cannons, but they're machine guns. So they go through the whole safety brief, and they get to the end, and Gunnery Sergeant Traver says to us, does anybody have any questions? And so I raised my hand, and I'm like, hey, Gunny, like, are you guys going to pass out hearing protection? And Gunny said, are you going to wear hearing protection at war? I'm like, well, Gunny, I never really much thought about it. I mean, then why would you wear it when you're practicing for war? All right. So we got out there with the 50 cals and no hearing protection, you get done, your ears are ringing. So
yeah, that sounds about right.
So that's a long story of I can't hear a darn thing anyway. So I will say I want to keep my vision so I can keep looking at diagnostic imaging, but I will lose the hearing.
That is okay. So if you have listened to Colonel Silvernail's episode, which was episode 2, the one right before this, I said he hands down had the best answer to a would you rather question. And I don't know, this might be really close. Like we'll have to put it to a vote, I think. All right. Second question, final question. Would you rather be able to talk to animals or speak all foreign languages?
God, I think speaking all foreign languages would be incredible. I mean, I don't, where I live, I'm not really engaging a whole lot with people with that are speaking different languages. Although I would like to communicate with my dogs at times, but I think speaking all foreign languages would probably be the better skill in that regard.
Yeah, I think I'm probably with you on that one. Although I really do want to talk to my dog sometimes. I want to know what she's thinking.
Yep.
All right. Well, that's a wrap for episode 3, but I do want to do a follow-up to this episode. And I think it's going to be awesome talking about those 2 topics that I mentioned previously. Make sure you go ahead and, oh my gosh, how did I not even mention this? We have a musculoskeletal imaging series at Redefine Health Education. So Lance Mabry is taking the lead on this, and we are already putting it out. So we already did one course last week, Introduction to Musculoskeletal Imaging. You can find that on demand in our on-demand courses. You can also come right in to another live virtual course on July 24th. I was like, wait, June, July. Okay. It's July 24th, Saturday morning, July 24th. You can join in on that. And then we also have musculoskeletal imaging of the hip and pelvis in August, the knee in September, the thoracolumbar spine in October, and the cervical cervical spine in December. And we will be coming up with the extremity courses in 2022. So please check out our website at redefinehealthhealth.com and keep a lookout on a certification program. We are in the midst of developing that. Any questions, send an email to info@redefinehealthed.com. And if anybody wants to reach out to you, Lance, how should they get connected with you?
Probably the easiest way is through my email, lmabry@highpoint.edu, or I am pretty active on LinkedIn. I'm not really on any other social media. So if they want to look me up on LinkedIn, I tend to put a lot of imaging content on there so they can keep up.
Awesome. Great episode. That's a wrap.